Welcome to this edition of the Neurology Video Journal Club. My name is Dr. Leslie Hayes. I'm a neuromuscular neurologist at Boston Children's Hospital. Today, we're going to be talking about a paper published in Neurology this fall titled Neuromuscular Features in X-linked Myotubular Myopathy Carriers, a cross-sectional study in an unselected cohort. It's published by a group out of the Netherlands. I'm joined today by my colleague and mentor, Dr. Basil Darras, and I'll let him introduce himself.
Thank you, Dr. Hayes. I'm Basil Darras. I'm also a neuromuscular neurologist, and I'm responsible for the neuromuscular program at Boston Children's Hospital.
We're going to start the discussion today by going through a summary of the paper. In order to even start talking about X-linked myotubular myopathy carriers, I want to make sure the audience is familiar with X-linked myotubular myopathy, which is a subtype of centronuclear myopathies. It's an X-linked recessive, pretty severe infantile onset myopathy that's caused by pathogenic mutations in MTM1, which encodes for myotubularin. The incidence is about 1 in 50,000 live births. As I said, the onset is typically in infancy, although there are some later onset forms. The classic form presents with severe hypotonia and weakness in the neonatal period with respiratory failure and ophthalmoparesis. These patients do often become ventilator dependent from significant respiratory insufficiency, and life expectancy is poor in the first few years of life. This is considered a non-progressive condition, and sometimes there can be some improvement after the infant period. There's typically no cardiac involvement, and cognition is typically normal, as is often the case in many congenital myopathies. So these, as being X-linked conditions, these are typically males presenting during infancy. And today we're going to be talking more about female carriers of these mutations that cause X-linked myotubular myopathy. So this paper was a cross-sectional study of a Dutch cohort of X-linked MTM carriers. The females that participated in the study had either a genetic confirmation of being an MTM1 carrier or were obligate carriers based on a family history, for example, a son with X-linked myotubular myopathy. The patients were recruited through established neuromuscular centers in the Netherlands and through patient organizations. There were sort of 3 pieces of data collected from each of the participants. It included the medical and symptom history and genetic diagnosis that was obtained mostly through questionnaires. The participants were examined by neuromuscular specialists and had manual muscle testing, assessment of their contractures and scoliosis. And then they had functional tests performed, which included the timed up and go test and the 6-minute walk test. This was mostly a descriptive analysis. However, there was also some statistics done comparing features of manifesting versus non-manifesting carriers. Ultimately, 21 carriers were included in the study, 95% of which had genetic confirmation, and then 1 patient was an obligate carrier. The average age of participation was 44 years, and it ranged from 22 to 62 years of age. One of the main findings was that of the kind of non-biased cohort, about half were considered manifesting carriers of the disease. So 52% and 48% were non-manifesting. The range of symptoms varied, and the patients were categorized into severe, moderate, mild, and minimally manifesting disease. The minimally manifesting disease was sort of a new category as part of this paper and represented patients that had more isolated ptosis or facial weakness, whereas patients with mild, moderate, and severe had more evidence of generalized, typically proximal weakness. Patients on the severe end of the spectrum were typically non-ambulatory. Moderate required some assistance with ambulation, and in mild cases had some degree of systemic weakness. Very interestingly, 7 out of the 11 patients were not identified clinically as being manifesting. So their symptoms were only identified by being part of this study. They were not followed by a neurologist or other specialist in the field prior to participation. So the main results from this paper were the kind of detailed description of the clinical characteristics. As you'll see from the figure on the left, many of the women portrayed ptosis and facial weakness that was particularly asymmetric, which was a unique finding as part of this paper. And then on the right, you'll see in the top right is a summary of the symptoms that patients reported, such as significant fatigue or myalgias, muscle cramps. And then in the bottom right is a graph demonstrating the findings on exam between different areas of weakness, contractures, with reflexes, and sensory exam findings, predominantly the manifesting carriers exhibited. As part of the paper, they also looked into differences between manifesting and non-manifesting carriers. The one statistically significant difference that was identified was that manifesting carriers had more asymmetry in their grip strength on exam than the non-manifesting carriers, whereas other tests such as the timed up and go test and the 6-minute walk test, which were the functional assessments done as part of this study, they did not show a significant difference between manifesting and non-manifesting carriers. This paper was a summary of both manifesting and non-manifesting carriers that exhibited different clinical characteristics of the disease. And I'll now ask Dr. Darras to comment on what sort of this data contributes to the literature on MTM1 carriers.
Thank you, Dr. Hayes. As you have noticed, this study is confirmatory because a number of case reports in case series have described already moderate to severe disease manifestations in X-linked material myopathy carriers, including asymmetrical weakness and also skeletal asymmetry. The authors of this study have shown that roughly half of these carriers are manifesting based on a clinical in-person assessment, which included not only a manual muscle strength examination, but also outcome measures like time up and go and the 6-minute walk test. The results of this study supplement the findings of another study that was a questionnaire study on self-reported symptoms of X-linked MTM carriers that the same group conducted in the Netherlands a few years ago.
That's great. And what do you think are some of the strengths and some of the limitations of this study?
The main strength was the high participation rate. As you have noticed, the authors are confident that they have captured the vast majority of the XL-MTM1 carriers in Holland using lab reports, but also data from patient organizations and also from the National Center on Congenital Myopathies. As far as the limitations are concerned, a limitation of the study is that they only examined the Dutch cohort. Another limitation is that the current design did not allow ancillary investigations like electromyography, like muscle imaging, pulmonary function testing, or liver enzyme determination. To gain more insight into the neuromuscular and systemic features of manifesting carriers, I think future studies should be conducted in larger cohorts and include these investigations for deep phenotyping of these carriers. There's another limitation is that the classification of manifesting versus non-manifesting, which is based on limb girdle and interaxial weakness, may be flawed. And the reason is that this classification does not take into account the other features of XL-MTM carriers, such as asymmetrical skeletal growth, facial and oculomotor weakness, and possibly pneumothorax.
And I do think, I didn't mention it before, but they did comment that multiple participants in this study also had a history of pneumothorax, which was
Yes.
interesting. What are some of the other kind of interesting, striking, or unexpected findings in this paper?
Yeah, an interesting finding that many neurologists and even neuromuscular specialists may not be aware of is the fact there was mild asymmetrical facial weakness in many of these carriers, as you discussed earlier. But this seems to confirm a previous study that was conducted a number of years ago that also showed that the carriers can have facial asymmetry, which is not always related to the degree of limb muscle weakness, meaning that you may have a lot of weakness and not have it, and vice versa.
And, there are a variety of different neuromuscular conditions, such as myotonic dystrophy, or in DMD, we think about manifesting carriers. How does this sort of fit into that context of assessing, in this case, mothers of our patients?
Yes. In comparison, the prevalence of manifesting Duchenne muscular dystrophy, DMD carriers, is estimated between 8 and 22%, as you know. Whereas in this study, about half, 50% of carriers, they seem to be manifesting. And what's also very interesting is that recently there was a paper that described asymmetric muscle involvement in symptomatic DMD carriers, which sort of like similar to what has been reported in this paper and in another paper in the past. The other thing is that as we all know, when we have a child with Duchenne muscular dystrophy, we recommend carrier testing in the mother, and we should be doing the same for cases of X-linked myopathy in patients of any age. Not only, but also we should recommend it for other family members. In my opinion, even if they're not obligate carriers or highly suspected carriers, I think the testing should be performed to include other family members, female members.
One of the things I found interesting about this paper was the wide spectrum of manifesting symptoms, with some patients with very minimal or mild symptoms, and some patients having a fairly severe muscle phenotype. And then obviously some carriers that aren't even manifesting the disease at all and are sort of true carriers in the sense. Do you have any thoughts as to why we see this wide spectrum?
Yeah. I mean, as you said, we have carriers, we have minimal or very mild symptomatology, and these carriers may are probably underrepresented, not only in the literature, but also in the clinics, because these females, they are not sick enough to go to the doctor. And something I didn't mention earlier was the fact that the X-linked myotonic carrier story is very similar to that of women with myotonic dystrophy, who are sadly often only diagnosed after having had a severely affected infant. But again, and then we have the other end of the spectrum where we have females who are severely affected, and the question is why that happens. It could be one possibility would be X chromosome activation. As we know, in females we have random X chromosome activation, which means that it's 50-50, like 50% of the time in cells, the one X chromosome activated, let's say the normal X chromosome activated, in the other 50% of the time with the cells, the mutant X chromosome gets inactivated. So we have that balance that protects females from symptoms in the case of X-linked traits. Skewed inactivation means that this balance 50-50 is disturbed. You can have 70-30 or 80-20 or 90-10, meaning that the mutant X chromosome could be preferentially activated, or if the normal X chromosome is preferentially inactivated, then you may have symptoms. But that's not so simple because we cannot actually measure it easily, and it is difficult to prove it at the muscle level. I remember a number of years ago, we used to send a blood test for an X chromosome activation assay that proved to be inaccurate. Again, because this particular activation situation will be tissue specific. So we don't actually have a good test for that. So this is maybe a reason for this for the different degrees of severity in carriers, but it's unlikely to explain the different severity in all cases. Recently, the role of potential modifiers for X-linked-MTM carriers has been investigated. A study in 12 families showed variants in the killer cell immunoglobulin-like receptor cluster of genes in all non-manifesting carriers, but not in manifesting carriers, suggesting these variants may confer protection against a severe phenotype. So we may have also these phenotypic modifiers. The asymmetries could be explained possibly by tissue-specific X chromosome activation, meaning that in an area of the body, let's say one side of your face, you have a lot of weakness and atrophy. It's possible in those muscles, the normal X chromosome is preferentially inactivated, but it could also be what we call somatic mosaicism, meaning that the mutation is not present in all cells in the body, or there might be other mechanisms operative that we do not understand.
Wow, a lot of possibilities. So in X-linked myotubular myopathy, as you know, there have been some very exciting studies, gene therapy using an AAV vector, ASO technology, and others trying to, make meaningful headway in treating X-linked myotubular myopathy for the, infantile onset in males. How do you feel like that's going to apply to female carriers? Do you think that some of the female carriers, particularly the ones that are more severely affected, could potentially benefit from these therapies also down the road?
Yes, I think this is the value of these studies because they're epidemiological studies, but very important because they tell us what percentage of the carriers could be affected. And it is important because they may benefit in the future if we have a treatment that seems to be effective in boys or males with X-linked-MTM. The same therapy may be applied to treat some of the severely affected macular myopathy carriers. As you know, there was an effort to do gene replacement therapy for young boys with MTM1 mutations. We had severe form of the disease, and it was thought to be a very good target because the histology of the muscle is not severely affected, in this case, at least early on. It's just that this myotubular RNA, the protein, is not produced in sufficient quantities, and there was significant success in the beginning. These boys, they seemed to acquire milestones. They came off ventilators, walking, running around, and that was thought to be an amazing result. But unfortunately, there was a number of deaths that occurred in some of the children. I think the number is 4. 3 of them had received a high dose of the vector, but in one case, the child had received a lower dose of the vector. So it was not really the amount of the vector, and the reason was probably the fact that these children have underlying liver disease because they die from liver failure. So that study has been suspended. So the effort has been placed on hold. Unfortunately, there was another effort to downregulate the dynamin. The dynamin is another protein produced by another gene that can cause centronuclear myopathy, and that has been found to be overexpressed. Not only in MTM1 tubular myopathy, but also in other types of tubular myopathy. So and they tried to suppress the production of dopamine by using antisense oligonucleotide. Unfortunately, that effort failed as well because at relatively low dose of the ASO, they had significant toxicity. So that study has been suspended as well. There's also an effort to suppress production of dopamine using tamoxifen. Eventually, some therapy will be discovered, despite all these setbacks, which might be applicable to severely affected manifesting carriers.
I think those were the main questions that I thought were worth talking about in relation to this paper.
Yeah, I think we covered enough territory, but I think it might be useful to Hayes to if you could give us a little summary of the clinical signs and symptoms that should make a neurologist, a neuromuscular specialist, suspect carrier status in a female who may come to the clinic just for weakness without any family history.
Yeah, absolutely. I mean, of course, the family history, for example, a child, a male with X-linked myotubular myopathy is sort of a dead giveaway. But if you don't have that, there are, I think, other valuable, clinical findings that were described in this paper. It seems that most of the patients that are manifesting, if they have weakness, it's predominantly axial and proximal weakness. And then I think the facial weakness, particularly the facial asymmetry, is a very notable feature that is not seen in many other muscle diseases. And so should absolutely be a clue in a clinician's mind seeing, an adult woman with these complaints. Many of the patients experience sort of nonspecific symptoms like fatigue and myalgias and exercise intolerance and cramps, which we see, many of those patients in clinic. And then I think, other features that were highlighted included, some mild contractures, scoliosis. And then, as you mentioned, there are some unique tidbits that, are sort of nonspecific, like history of pneumothorax, for example, but I think are questions that are worth asking our patients because there are certain neuromuscular conditions that can be associated with those sort of non-neuromuscular manifestations. Obviously, a family history should, and if you're in the case of seeing the child in clinic, I think it's really important that we as clinicians also address care for sort of the whole family, and not, I think women should be having their own independent neuromuscular care as well as respiratory monitoring and things of that nature. And so having the appropriate counseling when we do diagnose a child with X-linked MTM1, and then also, taking into account the siblings, aunts, and other family members, and as you said, to get testing when appropriate.